Welcome to this GSA Momentum Discussion webinar titled Charting the Course, Patient Navigation for Anti-Amyloid Alzheimer's Therapies. This is the second of three in a series of webinars addressing different aspects of delivering amyloid targeting monoclonal antibodies for the treatment of early Alzheimer's disease. This series is developed by the Gerontological Society of America, or GSA, in collaboration with the Alzheimer's Association with support from Lilly. My name is Jen Pettis, and I'm the Director of Strategic Alliances, and I'm pleased to serve as the moderator for today's session. Before introducing our panelists for today, I'd like to share a few housekeeping items. Please type your questions in the Q&A box at any time during the webinar. We'll have a question and answer session in the last few minutes of our program today. Our program is being recorded today and will be available on demand on GSA Enrich by the end of today. Your feedback is important to us. Please complete the evaluation in Enrich following the webinar. And I'm delighted to introduce our expert panelists today. Dr. Tintin Chaversveli is a professor of neurology and neuroscience and chief of cognitive neurology of the Cognitive Neurology Division. She's also the director of the Neurodegenerative Disorders Center and Cognitive and Movement Disorders Clinic in the Department of Neurology and in the Department of Neuroscience and Physiology at SUNY Upstate Medical University in Syracuse, New York. She's also a professor in the College of Graduate Studies at SUNY Upstate and an adjunct professor of anesthesiology at Tufts School of Medicine in Boston. Dr. Greg Cooper is a behavioral neurologist practicing at the Norton Neuroscience Institute in Louisville, Kentucky, where he serves as Chief of Adult Neurology and Director of the Memory Center. He received his MD and PhD from the University of Kentucky before completing his neurology residency and fellowship in behavioral neurology and cognitive neuroscience at the University of Iowa. After leaving Iowa, he worked with Bill Marksberry at the Sanders Brown Center for Aging at the University of Kentucky, and he's been named PI of numerous clinical trials as well as authored several manuscripts and book chapters in the field of neurology. He's a fellow of both the AAN and the AAPL. And finally, Dr. Camilla Teixeira is a research scientist in aging and dementia at the Rockefeller Neuroscience Institute, or RNI. She previously worked as a researcher at the University of Maryland, Baltimore, and the National Institute of Aging. She's from Campinas, Brazil, and started her career as a sports scientist and decided to study the process of healthy and pathological aging to improve age-related neurodegenerative disease outcomes. She holds a PhD in medical sciences from the University of Campinas, Brazil, where she had the opportunity to engage in neuroimaging studies in search of biological markers associated with aging and Alzheimer's disease. In her role as a research scientist, Dr. Teixeira is developing cutting-edge study protocols that aim to early detect neurodegenerative diseases and help provide treatment to patients and improve their lives with their families. At RNI, she also runs a monoclonal antibody support group for patients and their families, and we're going to hear more about that today. Today, we're going to explore patient navigation as a critical component of the anti-amyloid therapy journey. Our expert panelists will share how they've prioritized making the dementia care journey, including for those receiving anti-amyloid therapies for Alzheimer's disease, accessible and manageable for patients and their families. To get us started, would you each tell us a bit about your practices in general? Dr. Teixeira, please get us started.
Thank you, Jennifer. Hi, everyone. My name is Camila. As Jennifer mentioned, I am a clinical neuroscientist, RNI, and I've been studying Alzheimer's disease and other dementias for over 13 years. I started working with the effect of physical exercise on the brain of patients with Alzheimer's disease to the impact of physical exercise on pregnant mice with a model of Alzheimer's disease, so all over the place from clinical to preclinical research. And more recent, my work actually focused on using Focused ultrasound to help deliver the treatment in the brain, especially monoclonal antibodies, and also exploring the use of Focused ultrasound as a neuromodulation device, right? But at the heart of all the research the main goal is not to find the cure, actually. We really want to help people, patients and their families, right? Better understand the disease, improve the outcomes by combining science, innovation, and the available treatments. I'm not a healthcare provider, as you guys know, but I do see patients and I talk to the families to understand their needs, right? Today at RNI, we have the Memory Health Clinic, right, that belongs to West Virginia University. And we serve the West Virginia rural areas and Western PA. So I believe right now we have almost 250 patients who are taking the monoclonal antibody. We started with one infusion center, which was at Morgantown, but now we have 7 throughout the state. So that's how we work with the monoclonal antibody.
Great. Dr. Chevers Valley, how about you? You're on mute.
Yes, thank you for having me to participate in this panel. I'm a professor of neurology and neuroscience at SUNY Upstate Medical University in Syracuse, where I lead the Cognitive Neurology Division and direct the Neurodegenerative Disorders Center. We are focusing on the patient care and the research as well. We created, for the past 5 years, we created biobank, electronic medical record database, and hopefully we will move forward with IPS-based research. But on a practical base, our cognitive and movement disorders clinic is a multidisciplinary academic practice within a large university medical system. We provide specialized care to a very broad patient population across central New York with a long...
Dr. Chevers Valley, excuse me 1 second. Are you able to sit a little closer or speak up just a little more? I'm having a bit of trouble hearing you.
How about now? Better?
Much better. Thank you.
Okay, all right, good. We have a very long-standing commitment to provide a state-of-art care to our patient population. We implemented anti-amyloid therapy soon after the lecanemab was fully approved. And we have been infusing since very early 2024. Our first patient was started in February 2024. So again, we are excited with the current state of our protocols, and I will be happy to share later on. Thank you.
Dr. Cooper, how about your practice there in Louisville?
Sure, thank you. So I'm part of a larger group with a couple of geriatricians and a couple of behavioral neurologists and additional advanced practice professionals and others. We're part of an integrated healthcare system in Louisville, Kentucky, which is a moderate-sized city. Our patients come from Louisville, but also surrounding states as well. We've also been, we were early adopters of the anti-amyloid therapies. We're right at our 2-year anniversary now. We've got a little over 250 patients that we've infused using both lecanemab and donanemab.
Thank you. Dr. Cooper, can you describe the concept of patient navigation in this context of Alzheimer's care, particularly for those receiving the anti-amyloid therapies?
Yeah, I can. It can be a difficult thing to really pin down, I think. I think a navigator and navigation services can encompass a lot of things. And in our case, we think of that as just one of the critical team members in the larger team that administers and supports patients. So in our case, a navigator can be involved from the very beginning, helping patient go through the diagnostic journey. They can be helpful in terms of education support to the patient and family. They can be involved in connecting to other resources and certainly can be involved in helping initiate and continue treatment with anti-amyloid therapies. I think of them as, in some degree, a single point of contact for patients and their families. and also someone that helps reduce the friction of what's unfortunately often a fairly inefficient healthcare system.
Why is it so important to have patient navigation for
Well,
individuals receiving these new treatments?
so I'll answer that, and bear with me. I might even expand a little bit. So in terms of these treatments specifically, they're complicated and they're daunting. It's not a simple pill. It's not a prescription of donepezil I can give out. And so there's a lot of education that needs to go into that. There's a lot of logistics in terms of organizing the infusions, getting to and from the infusions, monitoring after the infusions, and then simply the MRI monitoring, looking for ARIA, can be fairly difficult. So having that one person that helps oversee all of that, I would argue, is as important for the system as it is for the patient and their family. But I think navigation services, frankly, can go beyond that and can be an enormous source of support for the whole family, even beyond just treatment with an anti-amyloid therapy.
And what would you say some key characteristics or qualities of a person that makes them a great navigator?
So they have to be organized. They have to be almost so obsessive compulsive you would want to treat them if they weren't your navigator. You really want them to be very organized. They need to be patient. Dealing with these medications, dealing with insurance, dealing with scheduling is all difficult. So they need to be patient. They need to be compassionate. And really, above all, they need to really be passionate about providing care for our patients.
Great, great. Dr. Chevresveli, during our past conversations, you've shared with me quite a bit about patient flow at your clinic at Upstate, including that your systems allow you to write an order and then the team moves the patient forward from there. Tell me about the order set that you've implemented that serves as a basis for that patient's care.
Sure, I'll be happy to. And to improve the efficiency of our workflow, we decided to create the electronic medical record order set. We have Epic, and we really front-loaded our work. And what we did, we created order set, and that included the initial diagnostic workup, subsequently implementing anti-amyloid therapy, and then the monitoring system. So really, this is entirely, our process is entirely really automated. And that ensures the standardization as well. So stepwise, it's quite simple in our system. It's the initial diagnostic workup, then eligibility, diagnostic confirmation, safety evaluation, then treatment authorization, infusion scheduling, and monitoring. So these are the steps. And actually, in this system, anti-amyloid therapy lead nurse navigator plays the most crucial and essential role, really. And I want to emphasize again that it's all about the automation. And we did really, honestly, without any additional dollar. And it was really a team effort. A lot of was done on our team member enthusiasm. And really, it was a team-based work. And our team includes physicians, a couple of them, and moreover, bigger pre-authorization staff, nursing staff, nurse practitioners, our colleagues in neuroradiology as well, neuropsychology when we need, and also inpatient teams in case this patient end up in the with some in the ED emergency department. So once now these days I just write the order, I place the initial order, and then it's all actually automated. And exactly the lead nurse navigator is the one in charge, is the point person. She works very closely with the pre-authorization team. And after the initial order, the Epic Chat message goes to everybody. So this patient has been enrolled. And
Chair Sally, you've also told me about some coordination with your stroke team in case of emergencies. Will you just mention that?
Absolutely. So we actually developed the stroke protocol / ED visit protocol for these patients together with the stroke team and the neuroradiology team. So if someone's, and it's very streamlined, if someone ends up in the emergency department with side effects / stroke mimics and is on anti-amyloid therapy, there is a very specialized pathway how we approach the screening from the clinical and imaging standpoint. So that's a part of our EPIC order set. So everybody is on the same page this way.
Terrific. Thank you. Dr. Teixeira, how does your team ensure that patients are well informed and supported throughout the therapy process, from eligibility screening to post-treatment monitoring?
Right. It's, it's listening to them, it's almost the same, but again, right? At the Memory Health Clinic, what we have is things from the beginning. When the patient comes, the first visit is they meet with neurologists and the neuropsychologist at the same time for about 1 hour. Right after that, they go and do some cognitive tests. And if they can, and if we have available, they are brain IR scan, right? So in the following week, what do? We have a memory conference. So all the Memory Health Clinic, they get together, neurologists, neuropsychologists, and the nurses to discuss all the cases. And then we decide, okay, do they need more testing to be done? Either amyloid PET, FDG, LP, etc. And then once the diagnosis is confirmed, what they do is they go again through the case and check if the patient doesn't have any contraindication for monoclonal antibody. For example, microbleeding, right? Or if the patient has a family support. Because we know, as Dr. Cooper said, it's not a pill, right? You need to put a lot of effort on that, right? So then what they do is they call the family, they call the patient, they explain the whole thing about monoclonal antibodies, saying there are risks that come with the treatment. And also there's time and effort that the family and the patient need to input. And if the family is okay with that, they move forward. So after that, after the first infusion, we have a whole team only to support the monoclonal antibody treatment patients, right? So they send messages through my chart, they send emails, phone calls. They have a booklet to showing the schedules with infusions and the MRIs, right? So essentially, this is a parallel system that we have at the memory clinic, just designed for the patients under the monoclonal treatments, right? As we know, and everybody else said, not only they have the infusions once a month or twice a month, but also MRIs. So the clinic needs to be closely tracking everything with the patient, right?
Okay. And what types of educational strategies? You mentioned a booklet and lots of different ways you communicate, but what other educational strategies have your team used for the patients?
I think the main thing nowadays is my chart. They have a very good communication. And now, from more than 1 year, we have the support group. They use me as a communicator, but not only that, because the nurses also come to the support group. And then when they see them there and they introduce themselves every meeting and giving, hey, talk to me through my chart. My chart is a very good tool, actually, to talk and ask questions about any kind of medication or any future appointment. So the main thing right now is a booklet, our support group that we try to educate them more about the research, and my chart.
Great. Okay. Dr. Cooper, what does building an effective and sustainable navigation model look like in a private practice?
So that one is also a little bit difficult to say, because I think it can mean different, or it can look in different ways. I will tell you, when we first started out, I'm a little embarrassed to say we didn't realize immediately that we needed a navigator. Fortunately, we realized that fairly quickly. We started out with our team. We had, in a practice like ours, we needed executive support. We needed an operations lead. We needed a team that included pharmacy, infusions, all of those things. But then we quickly realized you have to have a navigator, and really, you have a navigator, the patient, their family at the center of all of this, and the rest of our team and our support services kind of circle around them. And I think then in a successful program, there at the center of our program, we have frequent scheduled meetings. We have essentially continuous communication, and that person is the first point of contact really with patients and their families. And then in our case, um, that is a sustainable program uh, because of the essentially the downstream revenues that we get from the infusion program. That is not to say that we're generating large amounts of revenue. We aren't, but we're generating enough revenue in terms of infusion centers, pharmacy services, imaging, that then we can offset the cost of that navigator. I will say, if you give me just a second, we also have a separate sort of parallel navigator program that works not directly in the anti-amyloid space, but in that case, we've made that sustainable by using different navigation codes that we can bill Medicare, principal illness navigation or principal care management codes. And in that way, we've created a couple different navigation tracks that look like they're going to be sustainable long term.
Right. When you look at, you mentioned financial return on investment, but from a quality perspective, think about return on investment of that, of kind of both of those streams of navigation from a quality outcome standpoint.
And I'm glad you said that because that's really the purpose of this. Our goal is to be, quite frankly, our goal is to be break even so that we can continue them. And the real reason we're doing this is the return in terms of quality. So if we look at just anti-amyloid therapy, I think there's no question patients, families are thrilled with the navigator. They would probably argue that's the single most valuable thing that we offer. And I think from a system standpoint, it increases not just our quality, but our safety considerably. If we look outside of anti-amyloid therapies, again, it's the quality. Now we're able to look at patients not just as individuals with a diagnosis, but we're able to look at the entire family. And these, quite honestly, are conditions that affect the entire family. So if we're able to wrap around the entire family those services and the support, then we have really increased the value that we're giving in our clinic. So that's really the value. Our goal is to break even financially and then generate this value that we can continue to scale up over time.
And what advice would you give someone who's in an organization that's exploring starting such a model?
I'd say the first thing is create your team. And as part of that team, you need to go as high executively as you can to get support. So we basically had the number two in charge of our healthcare system, and when he's on board, it's difficult for anyone to resist us. So that was important. And then you need an operations lead. I'm not bad at operations, but I have another job. So you need someone that is good at working the system. Then you need to have all of the other stakeholders. You need to have their voices. And then you need to communicate twice as much as you think you need to communicate. You need a regular cadence of meetings. You need open communication, and you need to map out your process. Now, as part of that process, you do unfortunately or have to look at the finances of it and understand where the revenue is going to come from and how you're going to pay for this system. And in our case, we looked at those different navigation codes. We looked at downstream revenue. And I think once we had that process mapped and we could forecast what the revenues were, still a lot of work, but at least we knew the path forward, and it's worked fairly well.
Great, thanks. Dr. Chevisfeli, how do your nurse navigators help patients and their care partners navigate the financial and logistics aspects of treatment, like travel commitments and insurance coverage?
Well, this could be a quite complex process, obviously, and we start these conversations at very early stage, actually, as soon as we confirm that someone can be eligible for anti-amyloid therapy. And this conversation happens, together with nurse navigator. We start during the clinic visit, and then after even clinic visit is completed, nurse navigator spends quite a bit time with the patient to educate different, options, also patient assistance programs, possibility of out-of-pocket costs, and subsequently works very closely with the pre-authorization team that schedules the patient for the infusions. And we have our infusion center within the department to really get the pre-authorization and then see where we stand if the medication is not approved. And unfortunately, that can happen too. So next thing, Central New York covers quite large territory, so our patient can come from quite far, and they require the coordination from the travel standpoint. They require sometimes to reschedule the infusions. So the nurse navigator is really the contact person for all these aspects, really. And, nurse navigator really acts as a liaison between the clinic, our clinic, and other departments, and the patient, and also outside providers. So, I cannot emphasize more strongly that how important the building of the proper team, and also someone who is capable to be capable to really organize, keep everything organized, and have a compassion, because this journey can be quite complex and overwhelming. So build the appropriate team. And one thing I have to also emphasize is that the process can slightly vary. There are different sizes of practices, right? From very small, from very large. Someone can have only 5 patients on anti-amyloid therapy, and someone may have 200 and something in between. But building the appropriate team is crucial regardless of the size, and I cannot emphasize more strongly, having everything organized, because organization is the key. Otherwise, no amount of team members can keep up, because these are many infusions, these are many patients, and again, organization is the key.
Great, thank you. Dr. Teixeira, you mentioned before your support group for patients receiving the anti-amyloid therapies. Would you share a little about the structure and logistics for the support group, for instance, what the objectives are of it, who leads it, and so on?
Great. So the support group is my baby. As a scientist, we think we don't have access to the patients, but I do. I like to talk to them all the time. And actually, the idea came after we installed the whole system, and we saw that with the monoclonal antibody treatments, we need a lot of communications with the family, with the patients, and they were coming to RNI to get the infusions. So then we decided, okay, let's have the support group for the patients and the families. However, it will be, the whole idea was, or still is, we want to have a communication, a connection between patients and families and the healthcare providers. So the whole idea is to meet once a month, right? Every month we have one of the healthcare providers showing up and say, hey, I'm here. Or sometimes I email the patient saying, hey, Dr. Malone is coming next month, prepare your questions. And then the other idea of this group also is they supporting each other. And that's very interesting because once you get the diagnosis, some people, they're like, oh my God, I have Alzheimer's, it's worse than cancer. Oh my God, I'm going to die. And then suddenly they realize that they can still help other people and they feel better. So every meeting, it's different in a way that they bring something new, a new topic, right? Or I bring something and they can share their experience. In the beginning, every meeting I used to ask, so who is in the treatment? How long? Oh, this is my first treatment. How did you feel? Or how are you feeling? Oh, I had a diarrhea. And then somebody, one of the patients, why? What did you eat before? Did you go to, I don't know, Chick-fil-A or something like that? You know, those kinds. And it seems so, I know it's like, oh my God, it doesn't matter. It does, because that's an experience sharing, right? Which make them feel much better. So yes, I'm the one leading the group. We do have, so the navigators, the nurse, they do come to the meeting. We also have the neuropsychologist or psychologists who take care of the caregivers also. They come to the meeting. And again, once a month, it's in person and remote. So we try to do both because yes, Zooms are very nice. Yes, we have a lot of people from far away, 4 hours away, but the socialization is the key, right?
And what are some common topics and activities? I know it's not just a lecture. I know you've got some neat activities going on. Tell
Oh
us about
yeah.
that.
So the main thing, of course, we try to bring, updates about the treatments that we have. The patients are very aware of everything, especially because now everything is in the news. Sometimes they send me topics. We have a meeting tomorrow. So one of the patients sent me, hey, what about this B3 with vitamin and then green tea, something that was published in Geroscience? I was like, what are you talking about? So I answer him, hey, I'm going to check. Or someone send me, hey, what about menopause and monoclonal antibodies? See, those kind of questions. I don't think people are thinking about that, right? So we talk about that, and we talk about some lifestyle changes that they should do, right? How can they change some actions that they take every day to have a better outcome, to have a better life, right? Everybody know exercise is good. Everybody know that good nutrition is good. Everybody knows that, yes, but can we really do? And when we talk about that in a group, they kind of feel that they have to change their habits. So next month they come and say, hey, you know what? I went for a walk and it was awesome, right? So those are the type of topics that we discuss, in on the top of the whole research that's happening outside, right?
Great. Excellent. Dr. Cooper, I had the opportunity to look at the Norton Neuroscience Institute Resource Center online, and it's really quite impressive. Tell me about that resource center and some of the other direct-to-consumer education efforts of the Institute.
Sure. So it is great, and to be very clear, it was here before I got here, so I can take no credit for it.
Yeah.
It was actually one of the reasons I was open to recruitment here. So the idea of the resource center is to be available throughout our Neuroscience Institute for all neurologic illnesses. And within that, they do an enormous amount of educational programming. Now, they will largely do programming straight to our patients or caregivers or the community in general. And so, for example, and we've added to that since we've started. So, for instance, we have a quarterly day-long caregiver training program that we do. We are getting into brain health. We're having a brain health retreat this weekend, for example. And then we have music classes. We have series for caregivers who are grieving, for example. We'll have art. I could not possibly be part of this, but they have a chorus for our patients. They would never allow me in that, I don't think. And then on the professional side, one of my partners has really taken the lead in this. We've done quite a bit. We have a yearly now virtual clinical updates in Alzheimer's disease-related disorders for primary care. We routinely participate in our primary care update, giving the dementia talk. Have a neurosymposium that we give yearly. And as a general rule, we just try never to say no to anything. So we give quite a few talks around community and surrounding communities. Hopefully that gives you an idea.
That's great. With you never saying no, I actually understand that you patients can self-refer. You don't even say no then.
They
Tell me
can.
about that.
So I have, I did this in my old practice, and I don't know if my partners like this or not, but we mandated when we started the memory program that they don't have to have a referral; they can self-refer, and that has pros and cons to it both. Um, One thing that I found in the past is patients or their families may have a hard time getting their primary care provider to agree to referring them on. And I didn't want that to be a barrier. Or maybe they are unwilling to refer outside of their system. And I'm not here to say it has to be Norton versus any other system, but people should have access to care. Now, it is true, we see a lot of self-referrals, and some may be appropriate and some may not be appropriate, but we've had the general stance that if somebody thinks they need to be seen, then we're going to figure out how to see them and go from there. So right or wrong, that's what we've done.
Terrific. Great. Well, before we get to some attendee questions, we have a little bit of time on this one, and I want to really welcome you guys to give us your thoughts. And that is to really look ahead. What excites you most about the future of the anti-amyloid therapies and what you've learned about improving care and access with this role of navigation? And so how going forward can we take this and improve experiences for patients and improve access to these treatments that are really changing lives? So Dr. Teixeira, I'll start with you.
Yeah, it is exciting, right? But I believe that not only anti-amyloid therapies, but also thinking about tau-targeted treatments combined with some technological advances and new interventions will allow us to better address the many types of Alzheimer's disease. And I say that because Alzheimer's is a multifactorial disease, right? Only anti-amyloid or anti-tau therapies are not going to cure or be the solution, right? And I understand as a scientist, we're trying to find new interventions, and we have been discussing that so many times. But what I believe is let's try to find a way that we can combine all the therapies. And this will be with the whole navigation, with the way that we are now navigating with anti-amyloid. I think this is a way that we can not only target what that patient needs, but also we're going to be able to make treatments more accessible to diverse populations, right? If you think about some people far away in rural areas or states that they're not taking monoclonal, or they don't have, I don't know, TMS, or they have a different lifestyle. If you think about once we are able to combine everything and educate everybody about it, I think the whole idea here is let's have the treatment more accessible to everybody and also personalize the care based on each patient's unique progression and needs, right?
Thank you. Dr. Chebasili, is the same question for you. What excites you looking forward, and how can we take learnings about patient navigation and apply them to improve outcomes?
Well, I will divide into three kind of sections. Most of all, I am really excited to expand the,
Speak up just a bit for us, Doctor.
So I'm
There you go.
Okay, better. I think I have to fix my computer audio. Anyways, so I'm really excited about expanding the access to anti-amyloid therapy. And I think this was a very pioneering and very crucial landmark stage in Alzheimer's disease and care. And this is, but that being said, more broader patient population in the US and throughout the world should have the access to these therapies. That's number one. And, well-coordinated care will be, and well-organized care and efficient care will be absolutely crucial to cross this, to reduce and cross these barriers in terms of the diagnosis, insurance, and logistical standpoint as well. I'm also excited that, about, we are moving beyond the current anti-amyloid therapies, and we have, next generation anti-amyloid delivery systems. And I'm talking about subcutaneous delivery of lecanemab that I believe will help the patients and caregivers, to reduce the burden. I'm also happy that, donanemab came out. There is a new protocol that addresses the safety aspects of donanemab. And moreover, from the future standpoint, I'm really excited about anti-tau therapies that are making their way into the clinical trials, and so much more. I cannot list all of them, but I believe that this will be probably the combination therapy down the road. But I think we all have to, celebrate this really landmark stage and, move forward. So I believe we are better positioned than 5 years ago. And I always tell my patients that, our conversations were different 5 years ago than now. And the hope is here. Thank you.
The hope is here. Very great. And Dr. Cooper, the same question for you. Looking ahead, what excites you most in the future of anti-amyloid therapies and improving outcomes with care navigation?
So a few things really. I think, first of all, I think this is raising awareness, excitement, helping get rid of some of that nihilism that we've always had in our field, and an understanding that now we can bend the curve, we can change the progression. And with that, I think it's going to allow me to partner more effectively with those in primary care to start diagnosing people early on. And really, there's good reason to think the earlier we make that diagnosis and start treatment, the more effective we'll be. So that's the first step. I will also say, and I hope I'm not too optimistic here, but I'm very excited about the possibility of secondary prevention. So in other words, looking at these medications in people who have Alzheimer's pathology, which may begin 10 to 20 years before they have symptoms, but they don't have symptoms yet. And those trials are ongoing. We'll probably know in 2 or 3 years. Is it possible that if we treat those people before they have symptoms, we can prevent them from having symptoms? And I'm, despite being in this field a long time, I remain an optimist. So I'm hoping that will be the case. And then when we think about navigation, I think really beyond the anti-amyloids, I have always thought that I had the easy part of the job. I can order lots of tests, I can make diagnoses, I can write prescriptions. That isn't that difficult, but that's not enough. Really, people need more education. They need support. The whole family needs support. And I think navigation is an opportunity in hopefully a financially sustainable way to provide that care that I haven't adequately provided myself. So it allows us to look at this more holistically and elevate the overall level of care for patients and their families. So that probably sounds a little overly expansive, but I think that's the direction we need to get.
Terrific. Well, thank you all for such a thoughtful and practical discussion. It's really been a great discussion, and it's clear what an important role that navigation plays for patients along this and the families along their treatment journeys. So we do have some time for audience questions. We're kind of right on time, which is highly unusual for me. So that's great. So I have a couple of comments from a fellow nurse here that I'd like to share. The one is just commenting on loving the question of care navigator in the support group where the individual is receiving therapy, but also their caregiver or care partner, and the importance of the socialization that is you, Dr. Teixeira, that you outlined. And I know Dr. Chevres-Valley has shared with me, she brings all her patients together for open houses and allows that interaction, which is really fun. And then also this idea of personalized precision treatment, saying how much they love that, developing alternate pathways to address those individuals who may have contraindications to the therapies or otherwise benefit from a different course of treatment. So I want to take a couple of other questions. And Dr. Cooper, I had asked you earlier about competencies or traits of a person, but I'd love to hear from Dr. Chevres-Valley and Dr. Teixeira around that. When you look at that person who's really helping steer a patient and really an effective person for that, I heard from one of you the other day that maybe it didn't need to be a nurse, maybe a medical assistant who had a really great organizational skills might be the right person. So Dr. Chevres-Valley, tell us about kind of your idea of traits for someone who's a navigator. What are the ideal competencies or training or traits?
So I think compassion and organization are very key factors. You should not be in the medical field if you have no compassion. That's number one, obviously. And this work really involves quite a bit complex steps. So you have to be very well organized. And you have to have good communication skills. And that's another thing. In my view, these are the three important factors. And when you promise something to the patient, you should deliver. That's really important because anything we say to the patient, they believe us. And it's really important expectations to set the expectations. And that's what our nurse navigator does. It's really in a very compassionate way, say these are our options, whether it's the assistant programs or other healthcare services, and then to do really the best. So again, compassion, communication, organization, and we should deliver whatever we promise to the patient. So that will be my, key comments.
Great. Dr. Teixeira, did you have anything you wanted to add about traits or training?
I think, I think the navigator should have at least a little bit of idea of what is a dementia care, right? And I say that, I know, again, I'm not in the hospital, but as a scientist, I've been working with a lot of people who does a lot of bench work and animal work. And I don't know, I remember asking this person, why are you testing, for example, the walk, the type of walk of the mouse? It was a Parkinson model. And they said, I don't know. And I'm like, have you ever seen a Parkinson's patient? So this kind of thing, and I bring it to the hospital. It's like, understand a little bit of dementia care, compassion, for sure, compassion, right? And they don't need to understand about the medication, but they need to understand what are the medications available. We can discuss a little bit about the clinical trials with them, not that they're going to, go out and talk about them, but really they need to understand what we do in the hospital and the whole system, right? Not only get someone that doesn't have any compassion with families and say, okay, just you go and, right? The first thing is understand what is a dementia care, right?
Great. Okay, great. Next question I'd like to ask is, if someone is in a smaller practice, you mentioned some of those, maybe 5 or 10 or 20 patients on the treatment, may not be able to have a dedicated navigator, but how could they identify what are key elements of models that you described? How could they identify what those key elements are and then kind of start somewhere? So maybe they can't have a full-time navigator, but how could they kind of put elements of navigation into place without a dedicated person in that role. And I'll open that to any of you or all of you.
Well, I'm willing to start out. I think it requires some creativity, but if it's a smaller practice, they probably already know they have to be creative. And I think it would be important to say, well, maybe we don't need a full-time equivalent, a 1.0 FTE, but how can we carve out that responsibility? So perhaps we have someone in the office and we make 0.2 of their time dedicated to this. If you just pile it on top of someone who is already working 1.5 jobs, you're probably going to have a hard time getting it done. So I would still say if it's important, carve out that time, realizing it may not be a full-time person, but find someone and say a fifth of your job is doing this. Or perhaps maybe it's multiple things. Maybe one person is responsible for working with insurance, and another person is responsible for scheduling infusions and scheduling MRIs and making sure those are done correctly. And maybe another person is really good at interfacing with patients, and that's going to be their job. So maybe it's done by committee. I know I'm rambling a little bit. I think you want to identify what are the tasks that need to be done and how do you divide them up? Is it part of one person or is it smaller parts of multiple people? But map that out, get that on paper and make sure they're clearly defined roles and responsibilities. That would be my opinion.
Dr. Chavisali?
Yeah, no, I will agree with Dr. Cooper, and I guess the organization, I mean, as a team leader, whoever starts this process, I'm talking about the physician. Physician is usually the one puts the program together. Has to come up really with the to spend in the beginning more time to organize. I cannot stress more enough. And whether it's on the in the electronic ordering system or on the paper, really very clearly define the roles, like Dr. Cooper said. And also, if you have the opportunity to ask your IT person to embed these electronic order sets in the ordering system, that tremendously helps the process and the flow. Because in our case, when I put the order set, I just specify, and it's usually schedules. It's, all these monitoring MRIs automatically go to the scheduler. All the infusions automatically go to the infusion center. So that's how we did not have, to be honest with you, much of financial dedicated resources or personnel. And it was our goal that we should make it happen. And then we brainstormed and said, okay, let's see how we can streamline the process. And this was our way. And it took us like 3 months to work with the IT people, but now it's way better. So that will be my suggestion. And then obviously you need then, whether it's depending how big your practice is, should be a dedicated person who is educated about anti-amyloid therapy. And because that will be the really liaison between, the patient and the caregivers and medical team. So that's absolutely crucial to avoid any complications.
Dr. Chavisali, I think this question might be for you. A nurse colleague asked, does the EMR alert the triage nurse if someone is in the emergency department that the patient is receiving the therapy?
So there is a kind of notification that this patient is on anti-amyloid therapy. And our system is slightly different. So that alert actually really comes for now to me, but we are planning to ask the IT to really forward that to our nurse navigator. But right at this moment, it really comes to me. because this is our IT,
But how about if that person is in the emergency department? Is they're giving them an alert in their chart there, right?
Correct.
Their EMR.
Correct.
Okay. And so I'd like to switch gears a little bit and just talk about how do we work with primary care? What advice do you have for primary care out there other than let's diagnose people early and accurate? How do we get them to you to get that first visit with you all to be successful? Dr. Cooper, why don't you start us out
Sure.
with that? What can primary
Sure.
care do?
So I think there are a couple different ways to look at this, and I think the way I've looked at it is arguably not the right way, but my opinion has been just please particularly ask the family member if there's a concern about memory, and if there is, just send them and we'll figure it out. I think a lot of people would find that a little bit too abrupt. They would like the primary care folks to do a little more evaluation, and ideally, a primary care physician or a provider could do an 88 or an MMSE or Montreal Cognitive Assessment, some type of simple screen to try to substantiate is there cognitive impairment. And ideally, they could do simple labs like a B12 and a TSH. And I might say ideally they could do an MRI. I will throw in the caveat that if we're considering them for anti-amyloid therapy, there is a great advantage to us being the ones to do the MRI because that serves as their baseline. And if that's done outside of the system, there's a debate on whether that's good enough or whether we need to repeat it or not. So I think in a perfect world, at their annual wellness visit, they would ask the question, they would do a simple screen, they might do the simple blood work. But I will tell you from a very pragmatic standpoint, I'm satisfied if they'll ask the question and send them our way if positive.
Great. And Dr. Teixeira Cheverselli, anything to add?
No, I think, even though I'm not a healthcare provider, I think one of the biggest things for PCP is ask. Some of them are, I think maybe now with the monoclonals, maybe less, but some of them in the past were concerned about, saying we should check your memory or just say, hey, it's okay. It's just something you were stressed. But no, we know that if the person or the family says there's something wrong, right? Let's check. So just send it to, Dr. Cooper, right? Send it wherever. Just try to dig, because if there is something, it's important to analyze. It is early onset, if it is an early onset. And now we have the medication, we have the tools to treat it, right?
And so my final question before we wrap up is, we've mentioned I think it was mentioned during our first webinar that was with some colleagues last week, we talked about that it's just a fraction of people that are eligible to receive these medications who are receiving them. So we have a whole bunch of researchers and clinicians that are watching this webinar and will watch it in the future. What can we all do to help increase patient access and patient awareness of the potential for accessing these treatments?
I'm happy to start. I think those who we started, we are on the longer path of this anti-amyloid therapy delivery. We have to help the community. That's how I approach that, to help the to help other neurologists, geriatricians, primary care doctors, whether it's initiating anti-amyloid therapy or screening the patients early enough, because only the specialized centers like cognitive clinics, they cannot provide, all deliver these, treatments. So I think education of the medical community to simplify the process. I think that's the key. and then help the primary care doctors in the screening process. And, it's very exciting that blood-based biomarkers are here. It's a different conversation, obviously. But again, we have obligations, those of us who we know how to initiate therapy and we have experience to help the community to start this, therapies to implement in their practices. So I guess that's the best.
Okay. Dr. Cooper, Dr. Teixeira, anything to add?
I think, I was thinking here is education, 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 so people can, trust the therapies. I think and you guys can talk more about it because you are American and I came here, I don't know, 6-10 years ago, and the whole health system for me is like, wow. But still, as a researcher, right, as we work for that and try to find therapies, I think educating people and healthcare providers and family and try to gain their trust again, showing results, showing what and not promising much, but showing good results. That's for me, it's the key.
All right. And Dr. Cooper, really quick last word from you.
Yeah, I think we need to find a way to support other smaller practices, particularly in rural areas, to provide this medication. I have patients come from hours away, and I hate that they have to do that.
So that's a great advertisement for next week's webinar, where that's titled Bringing Therapies Home. So thank you very much, our experts, for joining us today. I'm so grateful for your dedication to your work, to your patients and their families, and for your willingness to join us here today. And thanks to everyone who joined us for the program. And again, my thanks to our colleagues at Lilly for supporting the program in collaboration with the Alzheimer's Association. Thanks so much.
Thank you.